cause for death as of now, and it was in 30 years back in 90, it was 17. So CKD is increasingly a common cause for death all over the world. And unlike other NCDs like diabetes, hypertension, and heart disease, where the mortality has decreased with advance in treatment, the CKD has not yet started decreasing. It is still increasing. So not only is the prevalence of CKD all over increasing year after year, there is no sign of slowing down unless other chronic kidney disease. There is data on the incidence of ESRD, that is kidney failure, not CKD. It is estimated that around 2 lakh people develop new kidney failure every year in India. This is an estimate from a study based out of Bhopal. So this is not accurate data. It could be more or it could be less. It's possibly increasing year after year. In 2018, there were 1,74,000 patients on dialysis across India. This is again an underestimate. If you see the Prime Minister's dialysis program, state dialysis programs, and all have come after that. So this is many more than this as of I would say compared to 2018. So there is some data also showing that this is from indirect data. This is basically age standardized renal failure death rate. So death attributed to kidney disease. And like many other non-communicable diseases, the southern and eastern parts of India, as well as the northernmost part, have shown significant increase over between 2010, 2013, and 2000 over a 10-year period. There is a significant increase in deaths attributable to chronic kidney disease. So kidney disease burden is significant and it seems to be increasing. This is our own data. This is a systematic review and meta-analysis we did, and the prevalence is estimated to be 13.2% for India. This is all over India. There are regional variations. South India has more, higher compared to Northern India. It is around 15%. Rural area, you know that diabetes and hypertension is more common in urban areas, but for kidney disease, it is more common in rural areas compared to kidney. There is a reason for that. I will not be going into scientific reasons. We can discuss it at the end if you want. So, if you look at some other data, the prevalence of kidney disease is supposed to be around 15%, 20% in India. So, kidney disease is not as rare as it is thought to be. This is when there is significant underdetection, right? Yeah, then only a couple of slides on some basic concept. There is something called a conceptual model of CKD, where you can look at the progression. There are normal people, then there are people who are at increased risk of chronic kidney disease. So this is the opportunity for primary prevention. Then there is a stage where there is kidney damage, where GFR is normal, kidney function as it may be normal. Then it progresses to reduce GFR, and then kidney failure, and then death. And they can have complications attributable to kidney disease at any stage, attributable to kidney disease or the risk factors for kidney disease. So this sequence is important because kidney disease is a progressive disease, be it diabetic nephropathy, any other kidney disease. Most of them, chronic kidney disease is a progressive disease, and this gives us opportunity to intervene. It can be primary prevention, it can be secondary prevention, it may be tertiary prevention in the form of dialysis or transplant. And each stage, there are specific treatment strategies which we can adopt. We all know there are 5 stages based on the GFR. Less than 60 is when we say somebody has CKD based on GFR. It may be based on proteinuria also. So CKD is based on both GFR and albuminuria. Somebody may have GFR of 90, but if he is having albuminuria, that person is having CKD. Right? It will be CKD 1. So this is an important concept, and this is also useful in severity, assessing the severity of kidney disease. Okay, so with that, so there's another sort of definition and staging. This is basically risk assessment in somebody with kidney disease. So there are two most important risks we are concerned about. Of course, people with kidney disease are at risk of kidney failure. There are some other risks also. I will be coming to that in a next couple of slides. So this basically is risk stratification based on the GFR. Lower the GFR, higher the risk. Higher the albuminuria, higher the risk. This is also used for deciding treatment and when to refer kidney disease patients. So this is also, I would say, important to understand. It is not only GFR, but we also need to The risk also depends. Somebody may have normal GFR, say more than 90, but orange means he is at moderate risk of complications from kidney disease when the proteinuria is in the nephrotic range. So both of them are important in diagnosis as well as management of chronic kidney disease. Now let us go on to 10 practical tips. Again, these are just 10 things which I came up with. You will not find this in textbooks, but let us see what they are. One is that there is evidence to show that we should be doing a screening for early detection of. So this is something which all doctors and I would say as health system we should be doing early detection by systematic screening for kidney disease. So this brings in the question. The CKD generally is perceived to have no specific treatment. So what is the point in detecting it early? Can it help in improving patient outcomes in the form of survival, preventing kidney failure, other complications, reducing death, reducing mortality? Is it useful? I will come to that in a minute. Then, if you want to screen whom to test, should we screen everybody for kidney disease? That is not feasible, I would say, not a viable option also. So are there any subgroups where we should be screening for kidney disease, and how to test? Should we do an ultrasound scan on everybody? So that is a question which we need to address. So this is a slide which I like to project in most of my CKD lectures, because this is a very important concept. I think everybody need to understand when we are treating kidney disease. If you, this is the historical data of progression of kidney disease, right? In the 1980s, we didn't have any specific treatment like ACE inhibitors, ARB, and no, the SGL inhibitors were not there. So at that point of time, with somebody having diabetic nephropathy, the rate of loss of GFR was 10 to 12 ml per year. So that means if your GFR is 40 now, within within 3 years, you will reach GFR of 10. So you will be having kidney failure, right? So if you have 10 ml per year. Normal with aging is around 1 ml per year. After 40 years, all of us will start losing GFR. That's only about 1 per year. But if you look at it, it was 10 ml per year. So somebody, even if this GFR is 60, in 5 years, he will develop 5 years, he develop kidney failure of GFR less than 10. With the introduction of ACE inhibitors and ARBs, captopril, enalapril, ramipril, or delosartan, telmisartan, it actually decreased to around 5 to 6 ml per minute, right? So the rate of progression is less. With the more recent introduction of SGLT2 inhibitors and finerenone, both of which are useful in diabetes and kidney disease, they slow progression of kidney disease, and it has come down to around 2 to 3 ml per year in somebody with a diabetic nephropathy. So look at the difference. If it is 10, you will develop kidney failure within, say, somebody with GFR of 60 will develop kidney failure within 5 years. But if you use ACE inhibitors or ARB plus SGLT inhibitors plus finerenone in case of diabetic nephropathy, it will reduce to, say, let us say 3 ml per minute. So from 60 to 10, it has to come by 50 ml, right? 50 ml, if it is 3 ml per year, it will take at least 15 or 18 years. So you are delaying kidney failure, which should have happened by 4 or 5 years, to more than 15 years. So nobody will disagree that that's a significant achievement, right? So there is documented proof now that you can retard progression of kidney disease and significantly delay progression of kidney failure to kidney failure. You can postpone it by more than a decade or more. And in addition, of course, there are benefits of other complications from kidney disease. The second importance is, when you beat patients and most of the doctors, when somebody has CKD, their fear is about kidney failure, whether I will have kidney failure, whether I will need dialysis, whether I will need transplant. But if you look at data, if you take 100 people with kidney disease, only half of them live long enough to develop kidney failure, right? What happens to the other half? They die from heart disease. So, if somebody has kidney disease, the patient as well as doctors, we should be worried not only about kidney failure, but the patient having cardiovascular disease, heart attack, and heart failure. So, this is again very evident from this data. If you see, as the GFR comes down, the cardiovascular mortality rate is increasing right from 75. Okay, once the GFR is less than 60, it's even more. Lower GFR, it's much more. And this graph is even more striking. If you look at the risk of cardiovascular mortality in general population and people with end-stage renal disease, so this is about end-stage renal disease, right? The mortality of people at the age of 25 to 30 with ESRD is similar to that of the risk of 80-year-old person in the general population, right? So the cardiovascular risk is very high when you have ESRD. What it means is that if you have kidney disease, you should be equally worried about having a heart attack or heart failure, and in addition to being concerned about developing kidney failure. So these are, I think, the stages of kidney disease, the risk assessment, and what are we trying to do when we are treating patients with kidney disease. I think is very important for us to understand. We are trying to delay or avoid dialysis, kidney failure, and we are trying to minimize cardiovascular death. Both are equally important. So early detection, this is possible only if you detect them early, right? The earlier you detect, the more the chance that you will be able to delay kidney failure and minimize the cardiovascular risk. So whom to screen? So there are well recognized risk factors for chronic kidney disease. Hypertension, diabetes are the most commonly used, but people who have heart cardiovascular disease of any form, heart disease, stroke, peripheral vascular disease, family history of chronic kidney disease, because a significant proportion of kidney disease is inherited. It's not only AD-PKD, there are many other. We are increasingly recognizing it. That was not well recognized earlier. And there are other things also, like, for example, somebody with lupus, SLE, people who are obese. Obesity is a risk factor for both CKD as well as progression to kidney failure. Genetic risk factors, environmental exposure to nephrotoxins. This is not uniformly applicable to all places, but then there is something called CKDU. Abhilash mentioned about Tondaimandala nephropathy. So this is relevant for some regions, like Pondicherry, but may not be relevant for Kerala. Then CKD is more common in older age. It is not, it doesn't occur in younger age, but with normal aging, you tend to lose GFR, and you will have much more longer, higher prevalence of diabetes, hypertension, much more longer duration of diabetes, hypertension. So naturally, kidney disease is more common in older population. So that is one group where screening is helpful. And history of kidney disease in the past, not only AKI, nephrotic syndrome in childhood, acute kidney injury from snake bite from in the past, any other form of kidney disease in the past. These are all risk factors for chronic kidney disease, and these are the at-risk population where it is found to be useful screening. So screening is not recommended for everyone. Everyone need not go and get screened for chronic kidney disease. If somebody comes to you asking whether I have kidney disease, or whether I should test for kidney disease, first thing to do is to check whether they have any of these risk factors. If they don't have any risk factors, scientifically screening is not indicated. Okay, you can tell them no need to worry, you don't have to do anything. If any of these you have to screen. Now the question is how to screen. Basically, it is to do a creatinine and a proteinuria. What is recommended is albuminuria, which is not very freely available. It is more expensive, so it is okay to check proteinuria as well. But you have to check both. EGFR, which is calculated from creatinine. So just checking creatinine is not enough. We need to calculate the EGFR. Most of the labs, actually, if you see the private labs, they report GFR when we ask for a creatinine test. So we need to check the GFR, and so basically do a serum creatinine, albuminuria. Nothing else is indicated for screening. Scanning of ultrasound scan or anything else is not indicated. So for screening, you have to identify people at high risk, and in those you have to check the BP, of course, and then ask for a creatinine and proteinuria. If they have proteinuria or reduction of GFR, then of course they have kidney disease. Confirmation of CKD happens when it persists for 3 months, so you are supposed to retest after 3 months. If the abnormalities are persisting at 3 months, then you have to label them as chronic kidney disease. If somebody at risk is not having proteinuria or the GFR is more than 60, that means patient has no evidence of kidney disease at present. They are supposed to be retested every year, provided they have risk factor. If they don't have risk factor, you need not test them every year, right? So I suppose it is clear, whom we have to screen and how we are supposed to screen for chronic kidney disease. Now, the second question is what to do once you recognize that somebody has chronic kidney disease. How to manage them when should you refer? Should you refer all chronic kidney disease patients to nephrologists? That's something which we often see here. I am not sure it's not that common in Kerala probably, but here when somebody is found to have CKD, they are asked to go to a nephrologist and follow up there, right? So this brings back to the risk stratification. This is the GFR. Lower the GFR, higher the risk. So that is why the color is changing from green to yellow, orange to red. And higher the albuminuria. This is less than 30, considered to be normal. This is significant proteinuria. This is nephrotic range proteinuria, more than 3 gram. So even if you have normal GFR, by definition, CKD is below 60, right? Below 60 will be here, G3. But if you have normal GFR also, if you have proteinuria, you may be still at significant risk of both progression. Progression means rapid loss of GFR more than the expected 1 ml per year. It may be 5 ml per year, it may be 10 ml per year, as well as higher risk of cardiovascular disease. So these are the two risk factors these people are uh, uh, at risk of. So that is how they are classified. Low risk, where you need not do anything. Moderate risk, you need to closely monitor them and start intervention in the form of lifestyle therapy as well as pharmacotherapy. High risk and very high risk. Very high risk, usually it is recommended that the patient be referred to a kidney specialist for further evaluation. It may be for specific treatment or it may be for preparation for, especially in the advanced stages, they have to be counseled and they have to be prepared for dialysis initiation and transplantation. So, how to treat chronic kidney disease? As we all know, first for anything, be it diabetes, hypertension, any NCD, it is lifestyle. So, healthy diet, physical activity, nicotine use has to be avoided, and weight management, optimizing BMI. So, this is integral part of management of CKD as well, with or without diabetes, right? And first line therapy is use SGLT2 inhibitors, use renin-angiotensin system inhibitors, either ACE inhibitor or ARB, blood pressure control and diabetes control, and statin. So you might be wondering why statin is here. This is from the KDIGO International Guideline for Management of CKD. The statin is here because of the cardiovascular risk I showed you earlier, right? So it is not only kidney failure we are concerned about, it is about the heart disease as well. So the first line is that most of, if not all, there are some exceptions. If most of our CKD patients should be on ACE inhibitors or ARB, SGLT inhibitors, and most of them on statins. There are specific indications. We'll come to that. And then there are targeted therapies. So these are non-specific for anybody with or without diabetes and anything. If patient has diabetes, then you have to use specific glucose lowering therapy. We'll come to that in another few slides. The non-steroidal mineralocorticoid antagonist, I'm sure you must have heard about it, Finrenone, which is well proven in diabetic nephropathy. If the BP is not well controlled with ACE inhibitors ARB, we will be using other antihypertensive agents like amlodipine or cilnidipine or whatever we are comfortable with. And when there is other risk of atherosclerotic vascular disease, we will use antiplatelets. And then we have to look for complications of kidney disease in the form of anemia, bone disease, hyperparathyroidism, metabolic acidosis, and potassium abnormalities. And we have to screen for them and we have to manage them appropriately. We'll be discussing it briefly at a later date or later stage of this session. The third point. So one is to screen. Whom to screen, how to screen, we discussed. Once you screen, once you identify, you have to put them on treatment. You have to assess the risk stage, decide whether it's a low risk, moderate, or high risk for kidney failure and heart disease, and institute the guideline mandated therapy for CKD. But then there are certain aspects which I believe needs to be emphasized. So one is optimization of renin-angiotensin system blockade. So this is a very common problem including in JIPMER, our own medicine department are very reluctant. When suppose somebody is hypertensive or diabetic, if they come with a creatinine of 2, instead of starting ACE inhibitors, they tend to stop ACE inhibitors or ARB. Okay, so that defeats the purpose. So that is opposite to what actually is recommended, but is evidence based. Okay, so ACE inhibitors and ARB are first line. Okay, if they have hypertension, of course we have to use it. Even if they are normotensive, if they have proteinuria, then it becomes first line, right? And it is not only important to start, we need to up titrate to the maximum tolerated dose. So the maximum tolerated dose will be decided by the blood pressure level. Some people may not be hypertensive, but when you start, the BP may drop. Second part will be the potassium. Hyperkalemia may limit the dose you are able to prescribe. So it is not only important to start, say you start with telmisartan 20 or 40 milligram, we should not stop there. We should use every opportunity by checking the blood pressure as well as the potassium to increase it to the maximum tolerated dose, usually around 80 milligram of say telmisartan. If it is enalapril, for example, we will go to 40 or even 80 milligram of enalapril. So you need to up titrate. I'm sure you are all aware that when you start ACE inhibitors or ARB, the creatinine can go up to 25 to 30% is expected. Okay, so it's not due to kidney damage. So what we usually do is, that I personally do is, invariably I will be telling the patient, because this is one complaint that people get apprehensive when the creatinine goes up. They may think that, okay, you gave some medicine and it is causing more kidney damage. It is important to tell the patient, see, when you start this is going to increase your creatinine by 30%. So if it is 1, it can go up to 1.2 or 1.3. And this is supposed to be beneficial in the long term, because basically it is increasing because the ACE inhibitor ARB is reducing the hyperfiltration happening in the glomerulus pathophysiologically. And hyperfiltration is the reason why which there's progressive kidney disease, right? By you are taking care of the hyperfiltration, so the GFR will reduce a little, and it is not from kidney damage. So this is a very important thing. Neither the doctor nor the patient should be concerned as long as it is less than 25 to 30%. If there is a progressive risk, that is a different issue. Okay. And in addition to progression of kidney disease, ACE inhibitor ARB also offer significant cardiovascular risk mitigation and reduction of proteinuria. So ACE inhibitor ARB are one of the first line drugs which we should try to use in all patients with chronic kidney disease unless there is a problem, right? The fear about hyperkalemia is such that the International Society of Nephrology has come out with a toolkit to ensure how to deal with hyperkalemia. So if the patient is initiated on ACE inhibitor ARB, we are supposed to recheck the potassium in about 2 to 4 weeks. Usually, we'll check both creatinine and potassium in about a week or two. And if the potassium is normal, and there is no change in creatinine, or if the rise is less than 30%, you up titrate, you increase the ACE inhibitor ARB. You don't stop at what dose, you keep on increasing the maximum tolerated dose. If there is hyperkalemia, you are not supposed to stop the medicine unless it is life threatening, which is very, very infrequent. Okay, if there is hyperkalemia, pressure goes about 5.5, 5.8, we are supposed to do things which will take care of this by modifying diet, check other drugs. Patient may be getting, say, spironolactone, patient may be getting some other drug. And if you give them diuretic, if they hypertensive, you can start hydrochlorothiazide or chlorthalidone or a loop diuretic. Additional sodium bicarbonate and potassium binders may help in mitigating the hyperkalemia and continuing the um, ACE inhibitors, ARB. Right. So instead of stopping, we are supposed to make all efforts to ensure that the patient stays on ACE inhibitors ARB. We should not, our threshold for stopping ACE inhibitor ARB should be very high. Right. We should not stop it for flimsy reasons. If there is more than 30% rise in creatinine, then there is something wrong. That comes under the definition of AKI. We need to look for why this has happened. This is not expected, right? If patient is dehydrated, patient is on excessive diuresis, patient has hypoalbuminemia, patient is taking NSAIDs, or this is one situation where we have to suspect renal artery stenosis, which is common in diabetic, atherosclerotic patients. So in that situation, of course, you will stop ACE inhibitors ARB and use other drugs. So emphasizing the importance of using ACE inhibitors ARB, we should not keep patients away from ACE inhibitors ARB for small things like some amount of hyperkalemia and a minimal less than 25%, 30% rise in creatinine. But long-term benefits are much more. The other component, which is now well recognized, multiple studies, I am sure you are all aware about SGLT2 inhibitors, which came as glucose lowering therapy, but has a significant renal as well as cardiovascular benefit. So this is useful in people who don't have diabetes but has some evidence of kidney disease or has heart failure, right? So if as evidence stands now, all CKD patients, irrespective of whether they are diabetic or not, irrespective of whether they have proteinuria or not, should be on SGLT2 inhibitors if their GFR is more than 20 from kidney point of view. Right. For cardiac indications, you can give them even if the GFR is less than 20, even on dialysis patients we use if they have heart failure, right? But if your aim is retardation of progression of kidney disease, reduce proteinuria, then all your CKD patients should be on an SGLT2 inhibitors in addition to ACE inhibitor IRB if their baseline GFR is more than 20 ml per minute, right? There are some situations where you have to be careful. One is ADPKD. There is more and more data coming. Initial trials exclude ADPKD because there was some fear that the cyst may grow rapidly if you use SGLT inhibitors for physiological reasons. But there is data now showing that this is safe. So it is no longer a contraindication, but we even I think twice before we putting ADPD patients on SGLT2 inhibitors. Patients who are on immunosuppression, there is very limited data. They may be at risk of genital infection is a risk with SGLT inhibitors. I'm sure you must be aware. Because of glycosuria, they tend to develop melanopostitis and all genital fungal infections, right? So if somebody is on immunosuppression, that risk is more. So that is the reason we usually instruct them for good genital hygiene after voiding. Once they pass urine, they should clean their genitals well. That will reduce the risk of fungal infections. So again, we should make all efforts to make sure that these patients are taking SGLT inhibitors. Foot ulcers, because if you see the initial study with the canagliflozin, that is the only study which actually showed a higher risk of amputation. None of the subsequent studies showed this risk, but still, if the patient is having severe peripherovascular disease, some caution may be warranted. And ketoacidosis, especially type 1 diabetes, you are not supposed to use. If there is somebody else who is prone for ketoacidosis, then there are some type 2 diabetic people also who are prone for ketoacidosis. So in such patients, you have to be careful. So these are going to be only a small fraction of our patients. So I would say, as a general rule, all CKD patients, irrespective of their GFR, diabetes, or proteinuria, should be on an SGL inhibitors as evidence stands now, right? So, and it has become very cheap recently. So this is easy to use now also. Going on to the fifth point is about hypertension management. 130, 80, 140, 90 is not good enough. The target BP recommended by the KDIGO guidelines is less than 120, 80 for all CKD patients, right? Uh, More than 90% of CKD patients are hypertensive. So we need to put in antihypertensive measures. It will start with dietary and lifestyle changes like restricting salt. Salt should be less than 5 gram. So translating into sodium of less than 2.3 gram. And ACE inhibitors ARB are the first line unless there is a contraindication. And generally, we encourage people to measure BP at home. You have to instruct them how to tie the cuff and all those things. But if you do that, there are some instances where no, there is white coat hypertension, which is very common. If you are in the habit of checking that, the hospital BP recordings are invariably high in a good proportion of people. So it is better to have home BP records. We have to be careful about the BP lowering in some people, elderly, frail people who are at risk of falls and fractures, people who have very old, 80-year-old, 90-year-old, people who have malignancy, other significant comorbidities where the expected lifetime, because whatever be the ACE inhibitors, ARB or blood pressure control, blood glucose control, these are not benefits which are going to accrue in couple of years. It will take 5 years, 10 years. So what we are looking at is long term. Right. If your patient is not expected to survive in the long term for other reasons, then there's no point in being aggressive about this sort of treatment also. So limited life expectancy, frail people, prone for falls, people with the postal hypertension, which is a common problem in autonomic neuropathy in diabetics. So then these people we have to be careful. Everyone else with kidney disease, our target is 120/80, not 130/80, not 140/90, right? Diabetes is the most common cause of diabetes of kidney disease, especially in Kerala. In our place, that is not, but all over the India, it is around 30%. But I looked at the data from Kerala. Almost half of chronic kidney disease in Kerala is from diabetes. So I'll be dwelling a little more on management of diabetes. I am not an expert on diabetes management, but with regard to kidney disease, there are certain things I think which we all should be aware. Everything starts with the lifestyle. So this is again from the KDGO international guideline on management of chronic kidney disease and diabetes. Healthy diet, physical activity, smoking cessation, weight management is central to all NCDs, including diabetes and kidney disease. First line therapy includes metformin. So this is something which I would like to emphasize. It's not that CKD people should not be given metformin, right? If you look at the international guidelines also, and we practice also, what you practice is also they will be getting metformin. The first line, if somebody is having diabetes and is having kidney disease and we are starting therapy, we should start with metformin and SGLT2 inhibitors for the glycemic control, because they not only reduce blood glucose, they are safe, and SGLT2 inhibitors specifically have renal benefits in the long term, right? So the first line, we expect most of our patients to be on metformin, SGLT2 inhibitors, depending upon the GFR, of course, RAS blockade, and statin. Statin again for the cardiovascular risk, which I would like to repeatedly emphasize. The next line will include, so the first line will be SGLT inhibitors, GFR more than 20. Everybody should be on SGLT inhibitors, I would say. Metformin less than 30. If the GFR is more than 30, okay, so that will be in the creatinine, anything less than, say, 2.5 or so, depending upon the age and the other things. You are supposed to use metformin as first line. RAS inhibitors at the maximum tolerance. It's not only RAS inhibition, we should titrate it to the maximum tolerated dose. That is when the benefit is maximum. And moderate or high intensity statin, I will tell you the recommendation is if anybody is having CKD with the diabetes, irrespective of age, irrespective of any other risk factor, they do not have heart disease, stroke, they are supposed to be on statin. The current recommendation is CKD and diabetes, any age, no other risk factor, they should be on statin therapy. So most of our diabetic CKDs will be, all of them should be on statin. So SGLT inhibitors, ACE inhibitors, metformin, and statin, most of our patients should be on. Then, if blood sugars are not getting controlled, we will use GLP-1 receptor agonists. This is not that cheap, so I'm sure we'll have problems. So, usually, what we use is sitagliptin and the sitagliptin and linagliptin, because the linagliptin doesn't require dose modification. It is no longer sulfonylurea, and insulin is not necessary at this stage. Only if it is needed. Once you use these drugs, only the role comes in. In diabetic kidney disease, if proteinuria is persisting despite ACE inhibitor, ARB, and SGLT inhibitors, then they are candidates any level of proteinuria, so anything more than 30 milligrams. So microalbuminuria also is an indication to start finrenone, right? So if proteinuria is persisting, they'll be on 4. So these are called the 4 pillars of diabetic nephropathy treatment: ACE inhibitors or ARB, SGLT inhibitors, finrenone, and GLP-1 agonists are the 4 pillars of diabetic nephropathy. Most of our patients will have indication for 4. Right. What about the target HbA1c? Again, no single recommendation. It depends upon the comorbidities. The higher the more advanced stage of CKD, you will be more liberal. So it's anywhere between 6.5 to 8. If somebody is having very early stages of CKD, a patient has no macrovascular complications like coronary artery disease, peripheral vascular disease, stroke. There are no other comorbidities, diabetes, but has CKD, but no other comorbidities. Patient is young, they have good life expectancy. There is no hypoglycemia unawareness, is not a problem. Autonomic neuropathy is not there, and patient has good family support. Patient has good. Patient is able to take care of himself or herself. Then we should target a low HbA1c, which is recommended for diabetic without kidney disease, which is 6.5. So basically, you have to individualize. There is no, we should not be too lax with glycemic control, is what it means. Younger person, no comorbidities, early stage of CKD, we should treat them as somebody without kidney disease when it comes to glycemic control, with strict glycemic control. Older person, multiple comorbidities, coronary artery disease, family support is not there, autonomic neuropathy is there, we have to be careful. So we can be a little lax with glycemic control. Glucose lowering therapy, I already emphasized. Glucose lowering starts with physical activity and dietary changes and weight loss. So that is the first level of treatment. Then it is metformin and SGLT2 inhibitors, right? Metformin is there. It's not a metformin you should not use. In dialysis, you will not use if it is less, GFR is less than 30. We are not supposed to start. If GFR is less than 45, we are supposed to reduce the dose by 50%, but you can start. If somebody's GFR is 40 ml, 35 ml, you can start the patient on metformin. But if you normally start with, say, 500 milligram BD, you have to start with 250 milligram BD, and the maximum dose used will be around 1.5 grams. Okay, we routinely use, and I can tell you that we don't, the recommendation is to stop GFR less than 30 ml, but generally we don't stop. Okay, we will continue, we will keep them and nothing happens, right? There is some data on that also. So we need not be afraid of using metformin in people with kidney disease and diabetes is the bottom line. SGLT inhibitors should be there, most of them. First choice, first line therapy is metformin and SGLT inhibitors, followed by GLP-1 receptor agonist, which is preferred, but too expensive. Some of our patients will be able to afford it, most of them not. So in that case, we will do DP4 inhibitors. Most commonly used in CKD is linagliptin, followed by insulin. Other things are not supposed to be used unless you are unable to use the earlier ones, the more preferred option. Regarding metformin use, again from the KDIGO, there is a approach recommended. If it is less than 30 ml, you are not supposed to start. If it goes below 30, the guideline says stop. I personally don't stop unless it goes much below, say 20 ml or so. But then the guideline is less than 30, don't initiate. And if it goes below 30, somebody was on metformin, you are supposed to stop. If that is not the case, GFR is more than 60 or anything more than 45, you can use the normal dose, especially having kidney disease, but normal dose of metformin, you are supposed to monitor annually so that you are aware whether GFR is going too low so that you can reduce the dose or stop if the GFR goes below 30. In addition to the renal function, we are also supposed to monitor for B12 deficiency. B12 deficiency, what we are seeing is very common in our population. So metformin is a non-cause for inducing B12 deficiency, so it makes sense to monitor it beyond the first 4 years of treatment with metformin. So bottom line is do not initiate less than 30 ml. Use half dose between GFR of 30 to 45 ml. We are supposed to monitor eGFR so that we don't continue to treat despite GFR being low, and we need to monitor for B12 levels in those people with metformin treatment. The next 7 point is lifestyle modification programs. Very important, very difficult to do, I agree. But still, we need to make an effort. Dietary counseling is needed. I'll be coming back to the dietary thing again in some other way, but this is very important. Generally, we'll require a dietitian. I find it difficult. I do give dietary advice, but then I think it is better done by a dietitian. Sodium restriction, we have to impose. Protein restriction, I have specifically used the term moderation, not restriction, for various reasons. Protein restriction is no longer recommended in patients with kidney disease. What is recommended is not to take high protein. High protein is defined as more than 1.3 gram per kg. Normal recommended intake is 1 gram per kg. You should not be giving below 0.8 milligram per kg protein. So the catch here is, at least in the studies, whatever we have done in our part of the country, where I am working now, Tamil Nadu, Pondicherry, the average dietary protein intake in a South Indian diet, where people who claim to be eating egg and fish and meat, is around 0.7 gram per kg. So they are already on a CKD protein, lower than the recommended CKD protein intake. So we should not impose additional protein restriction on them. Otherwise, you will produce loss of skeletal muscle mass. Right. So it is important not to impose protein restriction. Don't allow them. If somebody is in the habit of taking meat, a lot of meat every day, and the protein intake is more than 1.2, 1.3 gram, yes, you can ask them to moderate it, but don't cut out protein from their diet. Right, and there are some specific things like, for example, using lemon tea instead of putting sugar, salt in it. People generally find it very difficult to stop salt. Salt alternatives are not an option for CKD because most of the salt alternatives has potassium. They have potassium chloride. So CKD, that is a problem. So salt alternatives are not recommended as a rule in. It may be okay for hypertensive people with liver disease, heart disease with normal kidney function, but if they have CKD, salt alternatives are not recommended. You have to reduce normal salt. You have to use normal salt, but keep it below 5 gram, and try use using some strategies like lemon tea or something, so that adding spices to your food to avoid taking salt. I am not sure how many of you have heard about this. This is a well-recognized entity now, something called the Life's Essential 8. This is from the American Heart Association. This is a presidential statement which had come a couple of years back. I would encourage all of you, not only for your patients, for our own health, I would recommend you read that. There is another paper which has come last year on the CKM, cardiovascular, kidney, metabolic health. I would strongly urge you to read that as a health initiative for ourselves. Basically, this is now evidence-based that these are important for your overall health, primarily cardiovascular health, which is important in CKD. Having a healthy diet, what you call Mediterranean diet or a DASH diet, participation physical activity 150 minutes in a week, you are all aware of that. Avoiding nicotine, basically meaning stopping smoking. Healthy sleep is well recognized. Now your smartwatches and rings and all will allow you to monitor this. We need to have healthy sleep, we need to have a healthy BMI, and we need to control our lipids, glucose and blood pressure. This is applicable to not only people with heart disease. This is primary prevention, applicable for anybody with hypertension, diabetes, kidney disease, or people without them who are at risk, right? So I urge you to, I will not be elaborating on this. This Life Essential 8 is a very detailed paper which has come out from American Heart Association a couple of years back. Next is proactive management of CKD complications. As I showed you, CKD goes through stages. With advancing stage, they develop complications from low GFR, anemia, bone disease, and cardiovascular complications. Iron and B12 deficiency are quite common. So if it is available, most of the government hospitals will not have. We ourselves didn't have B12 for a long time. So now we are testing, but then if possible, better to check. And most of them will require iron supplement. Some of them will require B12 supplementation. We need to monitor phosphorus, calcium, and if possible, parathyroid hormone. People tend to develop hyperparathyroidism with GFR less than 30 ml. So that may require phosphate binders and active vitamin D treatment. Acidosis is quite common, especially with GFR less than 30. And this may have to be corrected with sodium bicarbonate. Prescribing bicarbonate, now the problem I believe what we see is that over treatment, everybody with CKD is put on bicarbonate, which actually can be harmful. The evidence that bicarbonate acidosis correction will retard CKD progression is very weak. So the KDU has taken away that recommendation. The indication is not for retarding progression, but for preserving lean body mass and all other things. So if you are prescribing bicarbonate, you will be surprised that most of them, despite having stage 4 CKD, will not have acidosis. So if you are prescribing bicarbonate, better to check the venous bicarbonate and then start them on bicarbonate if necessary. Vaccination is important because most of our CKD people are diabetic. Most of them will be older than 50, 60 years. And one of the important cause for death are infections, right? So annual influenza vaccination is recommended. All, if you look at diabetes, CKD guidance, all of them recommend. It is difficult to implement in practice because it is not really available for our population. We tend to be a very poor population. They are unable to buy it. Pneumococcal vaccination again. So whoever is able to afford it, we make sure that they are vaccinated, including our CKD and dialysis patients. So pneumococcal vaccination and influenza vaccination is recommended. Hepatitis B vaccine is relevant for those people who will need dialysis and transplant. But in later stages of CKD, if you vaccinate, they tend to not develop protective levels of antibodies. So it makes sense to vaccinate them as soon as you make a diagnosis of chronic kidney disease, right? And it's also important to understand the schedule is different. You have to use double the dose. Normally is 1 ml and 3 doses. Here it is 2 ml or 40 microgram and 4 doses, 0, 1, 2, and 6 months. And this is difficult, but then I think it's very important to educate our patient. This is the 10th and the last practical point, because the primary reason I believe this is of alternative medicine use. The situation has reached such a stage that if I have a patient who is having chronic kidney disease, I have to assume this fellow is taking some Unani. In Tamil Nadu, the Unani is much more common. Okay, Ayurvedic or Unani medicine. So things have reached that stage that you have to assume that people are taking alternative medicine. They may be along with our medicines or without our medicines, but then these are known to be harmful. So it is important to understand what are the benefits, and try to tell the patients what is kidney, what are we trying to do by retarding progression. We are addressing cardiovascular arrest. People are not bothered. People are worried only about their kidney failure, whereas we are worried about their heart also. Infection risk is there. Then people believe that if you reach dialysis stage, then you will die. Which is not, people live for decades whether on dialysis and after transplant also. So educating them of early detection, the benefits of adhering to a systematic treatment early in the diagnosis of CKD, avoiding unnecessary and unproven therapies, all these are important. So we need to have a, this is not possible without a proper education effort, but then I think this is important. So those are the 10 tips I wanted to make. I'll be coming to that after a few misconceptions also I thought I should address. So one I already told you, kidney disease, many people think that it is compared to diabetes or hypertension or heart disease. This is rare. Okay, it is less common compared to heart disease. You have to agree to that. But if you look at prevalence of hypertension in India is 30%, diabetes all over India is 19%. In Kerala it is more, in Pondicherry it is more, but then the prevalence of CKD is 13%, and this is an underestimate, right? So it is not far behind diabetes at least. So kidney disease is common, right? And many people are not diagnosed because they are asymptomatic and they are not screened, right? So other thing is, people tend to know I didn't have any problem. I didn't have any edema. I didn't have any loss of appetite or breathlessness. I didn't have any urinary symptoms. I'm passing urine, so I don't have kidney disease. Kidney disease is silent. It can progress even in diabetic nephropathy. You will develop symptoms of edema, other complications once the proteinuria is significant or the GFR is low. By that time, it is no longer early, right? By the time symptoms appear, it is already advanced stages of CKD. You have lost the opportunity to prevent progression. So that is the reason CKD is asymptomatic in the early stages. Unless you screen for it, you can't detect it and you can't intervene. So makes sense to screen those people, but then don't screen everybody. We have to identify those people at risk, make sure they are screened properly using the proteinuria as well as GFR. Many people do only creatinine, that is insufficient. You will miss a lot of diabetic nephropathy and other kidney disease also. You have to do both. And if you detect, then you have to intervene. Many people think that painkillers and alcohol cause kidney disease. Yes, they can contribute to kidney disease. Personally, I don't believe, as a nephrologist, I don't believe that painkillers can actually cause significant kidney disease. Okay, they can worsen kidney disease. As a inciting event, CKD, it is problematic, right? So it's not that if you've taken diclofenac for some joint pain, you will immediately develop CKD. I don't believe in that. But diabetes and hypertension are the most common cause of CKD in India as well as globally. And using NSAIDs in somebody who is having kidney disease is harmful, so cannot use it. You have to use it sparingly, right? And alcohol is not a cause for kidney disease, right? But alcohol, if you are a heavy drinker, your blood pressure control, your glycemic control is a problem. And then you can have progression of kidney disease. But as a cause of kidney disease, I would say no. Alcohol is not a recognized cause for kidney disease, but alcohol is to be avoided for all other reasons, right? Uh, Drinking a lot of water. Many of our patients also take 4 liters, 5 liters and come with hyponatremia. So it is going to be harmful. There are randomized control studies which have looked at progression of CKD. Prevention, nobody knows, but progression of CKD, drinking water in excess of what is needed, dictated by thirst, is not useful, right? So excessive fluid is not necessary. Everybody should take sufficient water to pass around, say, 2 liters or 2.5 liters of urine a day. So it will be more in summer, less in winter. But then you don't take it so that you can prevent progression of kidney disease, except in very rare situation like an ADPKD. Scientifically, there is a benefit, but other instances, you should not be doing that. In people with later stage of CKD, it can be harmful, right? And people with heart failure can be harmful. So drinking a lot of water is no treatment for kidney disease. Dialysis and transplant is inevitable. So this is what I was talking about. Both doctors as well as patients think CKD means dialysis and transplant. No, half of them are going to die from heart disease. Okay, so we have to treat heart disease to prevent them from dying. And then there are a lot of intervention, as I already told you. which can prevent or postpone kidney failure by more than a decade. Right. So, but this is possible only on two conditions. One, you have to detect it early. If you detect GFR is already 20 ml, there's nothing to prevent now. Already progression has happened. So that is the need. That is the importance of screening people at risk to find it early. And once you detect, you have to intervene decisively. Give the MACE inhibitor ARB at the maximum tolerated dose, SGLT2 inhibitors, filtron when indicated, meticulously control BP and blood sugar. These are all difficult to do in real life. I agree with that, but we have to make that effort. And I'm sure no, this will be useful for our own colleagues or our own family members may be having these conditions. I think this is that is one other reason I would say it is important to be aware of these things. So the four pillars of pharmacotherapy are ACE inhibitors, ARB, SGLT inhibitors, the non-steroidal mineralocorticoid receptor antagonist, Finrenone, and the GLP-1 agonist, semaglutide, and there are more drugs now. Kidney disease is a disease of elderly? No. I'm sure you must be seeing CKD can happen in very small children also. Various congenital and acquired urinary tract anomalies are there. Nephrotic syndrome, glomerular disease can happen. A lot of genetic diseases are there. So CKD is not disease of only senior citizen. It can happen in young people. And young people, if they have risk factors, should be screened. They should not take it lightly. One cannot live with normal life with one kidney. This is more applicable for kidney donation. We don't get any donors. Okay, siblings and even spouse and parents are thinking many times about donating now, but there is sufficient data to show that solitary kidney is good enough. So it's not that if you have for medical reasons you undergo nephrectomy for say renal cell carcinoma or you donated kidney that you can't have a normal life, perfectly normal life. We have had at least 7, 8 of our own kidney donors going who donated their husband conceiving, delivering kids without even gestational hypertension or any other problems. And one lady delivered twice. Okay, so pregnancy is a stressor, right, of the kidney. So again, that is again a misconception, I would say. The other one which we often come across is the renal diet. If you ask me as a nephrologist, I would say there is nothing called a renal diet. Okay, there is no standalone, there is no uniform diet for people with kidney disease. The diet prescription will depend upon the CKD stage. Okay, different stages, whether they are requiring dialysis, will have different diet prescription. Their comorbidities, whether they are diabetic, whether they have heart disease, they have hypertension, their lab parameters, potassium, for example, acidosis, for example. So there is nothing called a renal diet. Renal diet is a misnomer. That term should not be used. We don't use it anymore. Uh, Kidney patients require individualized diet prescription, be it protein, potassium, salt, calorie, right? So there's nothing called a renal diet. It is individualized diet for people with kidney disease. Some of them may require actually protein supplementation if they are malnourished. Herbal medicines can cure kidney disease. This is a tweet which the Ministry of Ayush put out yesterday, saying that some 100 people and the typical non-specific terminology and mumbo jumbo about herbal medicines. There is nothing. In fact, I can tell you from our experience, we see a lot of people who are taking Unani medicines and other thing, and they come with rapidly progressive kidney disease. We have done biopsies. We have found mercury poisoning. We have published papers on that. We have found interstitial nephritis. So I would say strictly no for any herbal preparation. Unless 100 people is nothing. Okay, somebody has done some 100 CR of patient. There is nothing called CR of these days. I don't know. If you are put everything like the big red flag for a person like me. So herbal medicines are no panacea. There are proven therapies. What you have to do is, if you have risk factors, get screened, go on evidence-based therapy, and don't worry about your kidney failure and heart disease. Kidney disease is not preventable. To some extent, yes. To some extent, no. You can detect early. You can slow progression amounts to secondary prevention. So primary prevention may be difficult, but yes, to some extent, it is possible. So to sum up, CKD is common. I hope I showed you the data. It is common and it is asymptomatic in early stages. So the importance of screening. So you have to screen, but screen at risk individuals, not blanket screening for everybody. We have to check the eGFR because the creatinine can be deceptive. You may think creatinine of 1.1 is normal, but the GFR may be less than 16 especially older people. Right. You have to check protein. So make it a habit to, if you are testing for kidney disease, if somebody has kidney disease, make it a point to check urine protein or if possible albumin. Make sure all or most of your patients are on ACE inhibitor, ARB, SGLT2 inhibitors. Give attention to the life's essential 8, which I described earlier. Aggressively look for risk factors, smoking, dyslipidemia, blood pressure control, glycemic control, and put them on statins if there's an indication. Aggressive, it should not be very lax. Okay, unless there is a problem, we have to have aggressive BP and glycemic control. I think we will need a dietitian in most of our cases. Look for CKD complications like anemia, bone disease, hyperparathyroidism, hyperphosphatemia. Vaccinate most of your patients, especially the older people, people who have advanced stages of CKD, and patient education is important. So I will end there. I am happy to take questions. If there's any point which I can elaborate, I am happy to do it. Thank you. Over to you, Abhilash. Abhilash, are you able to hear me? Hello? I think you're muted, Abhilash. I can't hear you.
Unmuted.
Okay.
Can you hear me?
Yeah, I can hear you. Yeah.
If anybody wants to ask doubts or clarification, you can unmute and ask.
Yeah,
Or
so
you
I'm
can
seeing some
type it
questions in the this thing. I think Dr. Arun is asking, is newer ARB inhibitor significantly better than our dear losartan, telmisartan, and enalapril? The answer is no. Okay, with regard to CKD progression, it is a class effect, right? So it is important to have ACE inhibitors or ARB. It can be anything, including enalapril or ramipril, losartan. The important thing is to use them and use at the maximum tolerated dose. For kidney disease progression sake, you need not. There is no evidence to say that say candesartan is better than losartan, right? So it is perfectly okay. What I use in JIPMER routinely, what is available is losartan and enalapril. Right. Telmisartan also patient has to buy. We rarely write telmisartan. So yeah, we can use anything. Losartan, telmisartan, everything is fine. Rabies vaccination, no contraindication. These are basically only in immunosuppressed people. This is a concern. CKD patient, rabies vaccination is not a concern. We can vaccinate. CKD patients or they are on dialysis. Transplant recipient, there is an issue with live vaccines. But for CKD patients, dialysis patients, no concerns. We can vaccinate. The other question is Dr. Alok has asked when is erythropoietin indicated? Yeah, so erythropoietin is indicated when the anemia is generally when the hemoglobin less than 9. But then most of the pre-dialysis CKD patients may not need erythropoietin. So if they have significant anemia, just correcting iron deficiency, B12 deficiency may take care of the anemia to a great extent. So it is important to look for that. Give iron supplements if you are able to check iron. Yes, definitely. Try to correct, or you can look for peripheral smear, some evidence of microcytic hypochromic anemia and all. They can have anemia and deficiency without that also. So first we have to do that. And if the hemoglobin is staying below 9, it's better to use erythropoietin and bring it to it should not exceed 11. Okay, so target will be anywhere between 10 to 11. If it's exceeding 11, then you have to reduce or stop erythropoietin. But only a small proportion of CKD patients will need erythropoietin, in my experience. Stage 5 people maybe. Before that, not a large number. Any rule of N-acetylcysteine taurine combination? That is a question I expected. Nephro-save and Reno-save and all are left and right. No proven benefit. There are some studies which are basically animal studies, and these are not studies which have shown benefit with regard to outcome. So when you say benefit. Usually what it means is that at molecular level, functional level, you may be able to show a lot of difference when you give many agents. But then unless it translates into reducing the incidence of ESRD, kidney failure or cardiovascular disease, it makes no difference. Right. So from that point of view, I can tell you, people will tell you a lot of literature, but I have never prescribed N-acetylcysteine or taurine for CKD patients. I've been practicing nephrology for almost 20 years now. So I'm not convinced that it is useful. I don't use it in my patients. Heavy work in gym and high protein diet? No. If you don't have any kidney disease, if you don't have any kidney problem, perfectly okay. You can take high protein diet. You have protein supplements also. That is not known to produce kidney disease. Somebody is having kidney disease. If you take high protein, there is rapid progression, but that is not an etiology for kidney disease. So if you're otherwise healthy, you want to take protein supplements, no harm. Is there any role for Dr. Abhilash? Is there any role for drugs claiming to be nephroprotective? So the proven nephroprotective drugs I already discussed. Okay. Other things like taurine, N-acetylcysteine, not beneficial. Not supposed to be. I don't use it at all. Not even a single patient I have prescribed it. The other one, which I am sure most of you may be aware, is the amino acid supplementation, essential amino acids. There are a lot of them also. So there is some benefit, but there is a very unique situation. It is not for everyone. Giving amino acid is not renoprotective. So that is, if you look at the guidelines also, this is in guidelines. There, in people whom you are expecting that they are progressing and they may need dialysis and you want to delay dialysis, you can use very low protein diet of say less than zero point 0.6 gram per kg, right? That normally it is not recommended. Normally it is not recommended, but in selected patients who are not malnourished at baseline, their BMI is normal, their lean muscle mass is good, and you want to delay progression, delay dialysis, you can put them on a protein diet of zero point 0.6 gram per kg with supplementation of essential amino acid. So essential amino acid by itself is not useful. It is supposed to be used, and that too the dose is very high. Usually people will require some 10 tablets and all, depends upon the quantity. So this is a combination therapy. This is a regimen where in selected patients you put them on very low protein diet. That requires strong, meticulous planning from a very good dietitian. You put on a low protein diet and then you give them essential amino acid to make sure that the lean muscle mass is not lost. So that is one proven therapy. There is a lot of data on that, but that is not how it is being used now. So there is a problem there as well. If corticomedullary differentiation is low, so that is very non-specific. In most CKD, you will find that CMD is lost or not preserved. But you will see this in AKA also. In severe AKA, you can have loss of CMD. So that is a very non. It just tells you, it is a radiological picture telling you that there is something wrong with the kidney. It doesn't tell you anything about the level of GFR, level of proteinuria. So your risk assessment, your management, your treatment targets are all based on GFR, proteinuria, blood pressure, glycemic status. Okay. CMD is a very non-specific finding. It tells you that there is something wrong with your kidney. Then you have to do further investigation to find out whether the patient is having CKD, proteinuria is there, GFR is low, whether the patient is having diabetes, hypertension, the patient is having some other glomerulonephritis. So CMD per se, I will not say it is not useful. If suppose you do ultrasound for some master checkup and you find that your kidneys are normal size, but then CMD is altered, you need to suspect kidney disease. But it is not useful in either prognostication, deciding treatment, monitoring treatment, for example. No, it has some value, but not useful in all these in these aspects. Gym people using creatine powder, lots of eggs as protein source. What's your opinion? Yeah, no harm if you don't have any kidney disease, is what I would say. If you want to build muscle in moderate amounts, this will not induce kidney disease, provided no, you don't have kidney disease. So if you are concerned, better to test yourself. If you have risk factors like hypertension, diabetes, heart disease, or you have had kidney disease in the past, stone disease in the past, better to check just to be sure that you don't have any proteinuria. Your GFR is normal. Normal GFR is around 90 ml. So if you are okay, then no, I would say no harm. Studies have shown that it is not harmful. Dr. Rakesh has asked why ARB inhibitors are not seen in nephrology prescription in ESRD is mostly cilnidipine. So ESRD, there is a problem. See, ACE inhibitors ARB, as I already mentioned, two indications. One is retarding progression. People with ESRD, there is nothing to prevent progression. They already have kidney failure. So from renal point of view, there is no indication for preferring ACE inhibitors ARB, right? But for cardiovascular protection, yes. If somebody is having hypertension, somebody is having heart failure, ACE inhibitors ARB will still have some role. But if you see ESRD people, mean they are on dialysis. And 90% of our patients are on hemodialysis. I would say 95% of hemodialysis patients will have pre-dialysis hyperkalemia. So these people are on regular dialysis. They may be getting twice a week, thrice a week. If you take sample before dialysis treatment, a good proportion of them will have high potassium level. So they are at risk of hyperkalemia, right? And ACE inhibitors ARB can still produce hyperkalemia even if the kidney is not functioning. Because when you have kidney failure, there are other ways for your body to eliminate potassium, primarily through the gut. Okay, that is well documented. Normally, it's 90% through the kidney, 10% through your gut, normal healthy people. When you have kidney failure, this 10%, suppose it is 10 milliequivalent, the renal part is 0 now, but that the gut absorb will not remain 10. It will increase to say 20 or 30. And when you give ACE inhibitors or ARB, the excretion of potassium through the gut is also inhibited. So even if kidney function is not there, giving ACE inhibitor ARB will still have an impact on the potassium thing. So in dialysis patients, it is not that it should not be used. We also use it in a very small number of people where it is indicated, or when we have already used other antihypertensives, there is no other antihypertensive which is, some people require 5-6 antihypertensives, and provided there is no hyperkalemia. From kidney point of view, there is no indication. It is for hypertension control, cardiovascular indication, yes, provided it is safe to use with regard to potassium levels. I suspect that is the reason you are not seeing many prescription in ESRD patients. Dr. Swami is asking for inject or iron sucrose. Yeah, so I would say with regard to safety or efficacy, not much difference. But Ferinject is pericarboxy maltose is what I think you are referring to. It can be given as a single dose. So you can give 1000 milligram as one infusion, hardly any reactions associated with the infusion. Iron sucrose also don't have any reactions, but the you may see once in a while. The proportion is even lower with pericarboxy maltose. And iron sucrose, you are not supposed to give more than say 400 milligram in one go. Right. So usually we tend to give it even lower, 100 or 200 milligrams. So multiple days, multiple this thing. So convenience wise, practicality wise, you can use pericarboxy maltose. It may have lower reaction rates also. But efficacy wise, I think there is no difference. Next question is how can we metabolic board? So I suppose the question is how can we diagnose CKD, CKD mineral bone disease. So anybody with CKD, you are supposed to check calcium, phosphorus, and ideally vitamin D levels, 25 vitamin D levels, and the parathyroid hormone levels. It will not be symptomatic. So if GFR is less than say 30, we should periodically monitor serum calcium, phosphorus, the PTH levels, parathyroid hormone levels, and 25 vitamin D. Vitamin D not be done periodically. Once is enough. If they have deficiency, we are supposed to correct it. Hyperparathyroidism, we may have to treat. Okay, so that depends upon, it's a little complex. I would suggest if you are finding hyperparathyroidism, at least once you can send to a nephrologist so that he can look at other things and decide whether there is an indication for active vitamin D. Active vitamin D is mostly misused. Most people don't require it, and any level of PTH is not abnormal. Normal level is 65 or below, but at various stages of CKD, there is an appropriate level of PTH. If you have somebody with CKD stage 4, if you find PTH of 300, it is not abnormal. You are not supposed to suppress it to below 65. Okay, so treatment of CKD is not very straightforward. There is little evidence. There is very little evidence on how to do, what to do. But so that is why I'm telling we should monitor them once in say 6 months or so. If you find it normal, then once in 6 months you can monitor these things. And if there is significant abnormality, I would suggest that you can get a nephrology opinion before thinking of starting active vitamin D or other drugs for hyperparathyroidism. Breastfeeding mothers drink about 25 glasses of water or other fluids per day. Is it harmful to the kidney? No, it is not harmful to the kidney. When you need, generally, if you see, general recommendation, I would say is around 2.5 liters of urine per day. It is not by the volume you drink, right? So in summer, for example, in Pondicherry and all, the summer is even more hot. So the people may have to drink, say, 3.5 liters or 4 liters to have urine output of 2 liters. So that is important primarily from the renal stone point of view, stone formation point of view. But then that is one a rule of thumb. If somebody is lactating, somebody is having in warm climate, you can have more. It's not that. Their concern is not about kidney disease, but people developing hyponatremia, dilutional hyponatremia. When you take more than say 5 liters of, even if you take 3.54 liters, generally we don't find any problem. But that is not required. It's not advisable. Is all what I am saying. There is no kidney. It will not cause kidney disease by drinking more water. You can end up with having hyponatremia. What about amlodipine and cilnidipine? I am not sure with regard to Dr. Jamila is asking with regard to kidney disease, no difference. Both of them are good at blood pressure control. So blood pressure control will have some beneficial effect, but they are not renoprotective. In fact, dihydropiridine calcium channel blockers are known to increase albuminuria. So if somebody is having proteinuria, it is modest effect. It's not significant effect, but there is a modest effect on proteinuria. They are equally good. And I am not sure what is the reason. Generally, everybody using cilnidipine. Fortunately or unfortunately, is not available in our pharmacy. So we stick to amlodipine, right? But I would say it is equally good, equally bad. There is no difference. Kidney point of view, there's no reason to prefer cilnidipine over amlodipine, is what I would say. When to use sevelamer? Sevelamer is usually is used as a phosphate binder. So if you are having hyperphosphatemia, and the first line generally what we use is calcium base, calcium carbonate, calcium acetate. But then you can't use it if the phosphorus levels are very high. And diabetic people, I would say half of the CKD people in Kerala are diabetic. So they tend to develop vascular calcification. If you give calcium in significant amount, especially when they have high phosphorus, the vascular calcification tends to worsen. That is a very high cardiovascular risk. So, if somebody is having not very high phosphorus, they don't have vascular calcification, it's okay to use calcium carbonate or calcium acetate as the first line phosphate binder. Give it along with food. Check the phosphorus levels after a couple of months, 2 to 3 months. If it's reaching the target, continue. Sevelamer will be first line in those people who are having very high phosphorus levels and cardiovascular risk with vascular calcification. You can't use calcium. Then as first line itself, you can use sevelamer carbonate. Or it's an add-on therapy to calcium. You can't use more than 1.5 gram of elemental calcium in a day. That is the maximum dose recommended. Why I am telling 1.5 gram elemental calcium. It is not 1.5 gram of calcium carbonate. 1.5 means it will be usually more than 3 grams, so 6 tablets or 8 tablets of calcium carbonate. If that is reached, still phosphorus target is not reached, or if the patient is having a vascular calcification, better to use sevelamer carbonate. Need not use it as first line therapy, because if you look at evidence, sevelamer as an alternative to calcium based has not shown better outcome with regard to cardiovascular outcomes. So I would not use it as first line for hyperphosphatemia. Best time for renal transplantation CKD is early practical aspects. Yeah, so there's something called preemptive transplantation, where the I would say the philosophical principal point of view, the right time to do transplant is when the CKD is progressing and you know that the patient is going to require dialysis. On an average, people will require dialysis. Most people will require dialysis from clinical indication once the GFR is around 8 ml. Right. So at that point, if somebody has the option of transplant, they have a donor, they have the finances, they should plan for transplant. The right time is before requiring dialysis or around the time they are expected to require dialysis. No point in delaying transplant if it is feasible. provided the recipient is fit. Some patients may not be fit for transplant. Some people may not have donors. Some people may not be afford it, right? So then there's a problem. If all these things are there, the right time is at the same time as dialysis. Instead of going on dialysis, you can go on transplant. Or if you already started on dialysis, do it as soon as possible.
Can
Practical.
I ask a question, sir?
Yeah, sure, sir. We can ask.
I'm from Dr. Suresh from Trivandrum. So one thing is, what are the indications for renal biopsy in case of CKD? And the second is there any use in patients with vascular calcification by using vitamin K2 MK7?
Yeah, so good question. First thing is about kidney biopsy. So generally in kidney biopsy in CKD, we tend to not to do kidney biopsy for various reasons. For kidney biopsy, we do when we want to know what is the cause of kidney disease. But then there are logistic challenges in doing it. When patient is having CKD, the kidney size tend to decrease except in diabetic nephropathy, and the kidneys are hyperechoic. So visualizing the kidney is difficult. Normally we do it under ultrasound guidance. So visualizing and doing the procedure is difficult. Okay. And when the kidney is fibrous, the risk of complication that we often see when somebody is having higher than normal creatinine, proteinuria, they have CKD, for example, but you still want to do biopsy. A biopsy-related complication in the form of hematoma, hematuria requiring intervention, transfusion is much higher. And the other aspect, so technically it is a little difficult to do, not impossible, but a little difficult. Third, associated complications are more if they are having CKD. Third, if you do biopsy in significant CKD, you may not be, even after you don't have any complications, you manage to get the tissue, you may not be able to make out what is the pathology because it will be fibrosed. So we cannot go in with the assumption that we will be definitely be getting a diagnosis. So generally, we tend to do kidney biopsy in a person whom we suspect having CKD when there are some specific indications and when we think that the risk is acceptable. So that is a nuanced call we take based on our experience, our skill, and the indication. For example, somebody has diabetes. He was having CKD kidney creatinine was around say 1.52 for some time. Then there is a sudden rise in creatinine. There is suddenly hematuria. There is rapid worsening of proteinuria. So then we have suspicion that there's something else going on. We want to know what it is, whether it can be treated. So then we will do a biopsy. Provided the kidney size is okay, reasonably visible, and we have experience doing. So CKD, we have to be very selective in doing kidney biopsy. We have to be careful. Only when we have to look at the risk benefit balance. If it is reasonable, acceptable risk, and there is chance that it is likely to be useful treatment prognostically, then we can go ahead and do it. Only in a small fraction of CKD, we actually do. Second question was about the vascular calcification part. In fact, vitamin K is known to have some impact on vascular calcification. In fact, using warfarin, vitamin K inhibitors and all are known to accelerate vascular calcification. But to the best of my knowledge, the specific agent you mentioned, whether it will prevent vascular calcification, I am not sure. I need to look at the evidence for that. My understanding is that so far there is no proven therapy which is known to reverse or retard vascular calcification other than taking care of your diabetes, hypertension, the mineral bone disease, calcium and phosphorus and all those things.
Okay. So one more thing, in a hypoproteinemic patient, do you stick on to this 0.8 gram per kilogram protein?
Yeah, so it is not about hypoproteinemia. I would say it is about the nutritional status of the patient. Okay, somebody may have some hypoproteinemia, but if the patient is overweight and the lean body mass is patient is not malnourished. In that case, also you may not supplement protein because if you supplement protein, hypoalbuminemia may be from proteinuria. We still will keep it 0.8 to 1 gram only. We will not give them high protein diet. But what is important is the nutritional status. Hypoalbuminemia may be part of malnutrition. They may have low BMI. They may be having low lean body mass. In that case, yes, we should not restrict protein. Protein restriction, by the way, is not recommended in growing children, for example, even if they are having CKD. So there are situations where we should not restrict protein. So hypoalbuminemia, if it is part of, say, liver disease, patient has a malnutrition, then yes, we should not. We should actually supplement protein. I agree with you, sir.
Okay. Thank you, sir.
You're welcome, sir. There are a couple of other questions which I hope I can go on. Xanthine oxidase inhibitors, I hope you are asking about allopurinol. For retardation of progression of CKD, no use. Okay, so as such, asymptomatic hyperuricemia, if you look at evidence, there is no indication for using either allopurinol or febuxostat. Among the two, what is preferred is allopurinol, okay, because of cardiovascular protection. So if somebody is having CKD, patient is having hyperuricemia or gout, and patient is having heart disease, then for cardiovascular protection, again, it's not conclusively proven. Okay, but there is some evidence saying that it may have some cardiovascular benefits. But for retardation of progression, suppose somebody is having CKD and you have asymptomatic hyperuricemia 8, 9, no benefit from treating that hyperuricemia from kidney point of view. If the patient has gout, yes, you will treat. If the patient has heart disease, patient has coronary artery disease, then maybe. Okay. That's one situation where I consider treating with allopurinol. Otherwise, for kidney disease, no indication. Scientifically, it is not recommended also. Using ACR or 24 hours urine protein, which is preferred. So 24 hours urine protein ratio is cumbersome to do. It is mostly difficult and erroneous. So that is the reason it is not recommended. If you look at what is actually recommended, what is best is a timed collection, where you collect urine for a period of 6 hours. You don't collect it for 24 hours. You collect for 6 hours, 8 hours. Timed collection, and then do PC ratio, either albumin creatinine ratio or PC ratio in that. So that will take care of the diurnal or your variation with regard to posture and all those things. So it is a timed collection. So that is the optimum. If you look at guidelines, what for even diabetic nephropathy, for even glomerular disease, what is recommended is a timed collection of urine followed by protein creatinine ratio. For practicality purpose, we do protein creatinine ratio, but then better to do it at the same time, say in the morning or sometime. And serial monitoring, maybe fluctuation will be there, but yeah, of the two, practically I would say it is okay to do protein creatinine ratio. But if it is possible to do timed collection, that will be even better. That is what is recommended. Timed collection is not 24 hours; it can be 6 hours, 8 hours. Will spinach and drumstick leaves worsen hyperuricemia because we encourage young patient to eat? I specifically don't know about this thing about drumstick leaves and spinach leaves. I'm sorry. Drumstick leaves, I don't know whether there is any data. So I have to check on that. I'm sorry, I can't answer that question. I'll check, and I need to know myself. So I'll do that. Sorry about that, Dr. Rakesh. Dr. Uma Devi has asked, in patients with progressive renal damage, is it good to suggest dialysis and transplant to all patients as treatment options, or there are specific criteria? Of course, that is only for kidney failure patients, right? So the understanding is that, see, for you, somebody to remain healthy, to have a good quality of life and to ensure maximum life expectancy, you need to have certain level of kidney function. So that generally is, you will be able to manage without dialysis in most patients till about GFR of around 8 to 10, or say 6 to 8. 8 is the general figure, right? There are some people where they will need dialysis even when GFR is 8 or 11 or 12, that proportion is less. There is some people who will still be okay, not requiring dialysis when the GFR is 5. So those are exceptions. I'm not talking about those people. So only if those people, there is a clinical indication for dialysis, then dialysis is indicated. With GFR of 50, 15 or 20 or 25, they have CKD. See, because we have to understand that people with, say, transplant kidney has a life expectancy. On an average, I would say 12 to 15 years. So unless, if you do it early, suppose somebody has creatinine of 2, or you can ask, why don't you, kidney damage is there and he may develop kidney failure, why don't you transplant now? So your transplant life starts now. Right. Suppose you are able to treat and the patient is doing well on ACE inhibitors, ARB, SGLT inhibitors for next 10 years, and then you do transplant when the creatinine is, say, 6 or 7, your kidney life will count from then to another, say, 10 years or 15 years. But if you do transplant now, your kidney is going to fail in another 10-15 years, whereas patient could have lived for next 10 years with his own kidneys. So this has to be timed well. Be it dialysis or transplant, it has to be timed. So there is no cutoff value as such. You look at multiple things, whether they are diabetic, it is a growing child, whether they have cardiovascular disease, whether they have what sort of native kidney disease they are having, what is the nutritional status. So we look at multiple things, what all symptoms they have, whether there is refractory fluid overload, hyperkalemia, along with the GFR or the creatinine levels, and then decide on dialysis. We should do dialysis or transplant only when it is indicated. It is not indicated for all CKD patients or all stage 4, stage 5 CKD patients also. That's a very careful decision we need to take. You asked about specific criteria. No, unfortunately, there is no written criteria. Okay, it is a synthesis of, so that requires some experience. As a trainee, I used to get scolded for dialyzing people by my teachers because that was not indicated. So that requires some theoretical knowledge plus, I would say, a significant amount of practical experience managing this patient. So that is a slightly complicated decision you take. There are no specific written criteria which you can read out of a book and then decide on dialysis for a patient. Whether we have to treat hyperuricemia in a patient with MSD for renal benefit, no. I would generally not treat. If a patient is dialyzed well, then that patient is unlikely to have significant hyperuricemia. If you are saying hyperuricemia more than 7 in a male as hyperuricemia, no indication for treat. Unless there is gout, unless a patient has severe heart disease, even that indication I will not treat in a dialysis patient. So unless patient has symptomatic hyperuricemia in dialysis, I personally will not treat that hyperuricemia. Amlodipine and platelet edema, yes, it's a very common problem. So that is a very common problem, and that is the reason why I invariably prescribe amlodipine in the evening. Okay, we should not prescribe amlodipine in the morning because there are significant data showing that amlodipine as well as nifedipine, everything can produce dependent edema. It is difficult to treat. Usually will require a reduction of dose or changing to some other agent. But it can be mitigated to some extent by keeping the dose 10 milligram or below amlodipine. I generally don't prescribe amlodipine dose more than 10. That is the maximum recommended dose anyway. If you can manage with the 7.55, it is better. And always give the amlodipine dose in the evening at bedtime instead of giving it in the morning. So that will also take care of edema to a great extent. What was the other question? Any more doubts? Question: should we get test dose for sucrose injection? No, not needed. It's not recommended. We don't practice also. We don't give test dose for iron sucrose. That was needed only when the iron dextran era. So iron sucrose also, the reaction rates are very, very low. Provided you do use a good preparation. Okay, we use it left and right. Iron sucrose in our dialysis patients, CKD patients, you don't get any reactions. Very rare. Test dose is not necessary. That is extra cumbersome and that I would say totally unnecessary to give a test dose for iron sucrose. Not recommended, not needed. On follow-up transplant recipient on immunosuppressive diabetic follow-up given ACR, is it beneficial? Yes. We need to check proteinuria even in a transplant recipient is actually a CKD. He is having chronic kidney disease. He's on immunosuppression. The JFR will not usually be above 60, and a good number of them will have proteinuria. So in a transplant recipient also, we need to check for proteinuria, especially if they are diabetic. Even in non-diabetic, they can have recurrence of glomerular disease, IgA nephropathy, and all. And if they have proteinuria, significant proteinuria in transplant, generally if it is above say 500, we will treat. Treatment with ACE inhibitors, ARB, and all is indicated. So monitoring anybody with kidney disease or suspicion of kidney disease, we need to check proteinuria or albuminuria. When you check for creatinine, when you have to check for proteinuria, be it a transplant patient or a CKD patient, yes, we definitely have to do and treat if it is there. Dietitian advice in CKD in various stages, important opinion. Yes, of course. Dietitian advice is very important. And generally, it is very difficult to customize the diet for people because people have their own preferences. So we need to first of all, you need to have a very sensible dietitian who will listen to you. If you send to any dietitian, it happens even in JIPMER, again, institution like JIPMER. If I send a patient with any kidney disease to a dietitian, the dietitian will give so-called renal diet, low protein, low potassium. Yeah, they will tell them to not to take any non-vegetarian stuff, cut on dal, all those things. Completely wrong. Dietitian, what dietitian should first do is to take a diet history, and from that they can quantify how much protein this patient is taking. For example, the diet recollect what we call three idlis, dosas, or puttu, or whatever they are taking. Lunch, what you take, they can calculate the potassium intake, they can calculate the protein intake. If you find, I am telling you, 80% of your patient will have proteinuria, protein intake less than 0.8 grams. So you should not be imposing protein restriction on them. A dietitian should be able to calculate that. It's difficult for us to calculate. Dietitian should be involved. And dietitian also will be within the prescribed calorie, protein, potassium limitation. They can suggest dietary items which the patient may prefer. Somebody may not take like taking say upma, then they not take upma, they can take something else. They may not like taking some fruits, they can take something else. So that advice is best done by a professional. I think a dietitian is an integral part of managing CKD. Yeah, we should involve them at every stage. Sodium bicarbonate indication. So if it's definitely indicated if the bicarb is less than 18, and you should not overcorrect. If alkalosis is shown to have higher cardiovascular events in CKD patients also, so you should not overcorrect. Definite indication if it is less than 18 milliequivalents. Okay, if it is 21, 22 also, you do not necessarily treat it. Once you treat it, it should come to around 22, 23. Right. So the definite indication will be if the bicarbonate level is less than 18 milliequivalents. Sorry. Which is the most common drug producing analgesic nephropathy? You are asking a complex question. There is, see, this analgesic nephropathy is a historical diagnosis. It no longer is real. Analgesic nephropathy was described when, and it is not from NSAIDs alone. There was a combination where there was paracetamol, caffeine, and something called phenacetin. Right. So this is described with that thing, and that is not entirely from the phenacetin also. It is also from the caffeine component. So if you take, for example, Brufen, okay, I personally believe that it is very difficult for somebody to develop a CKD from eating Brufen, if provided he didn't have any kidney disease, no risk factors for kidney disease. So I don't personally. Okay, other nephrologists may differ in my view, but I am telling you there is a strong point of view like this. As whether Brufen, diclofenac, aceclofenac can produce chronic kidney, it can produce acute interstitial nephritis and AKI. Right, that is well known. It can happen. But that is an immunological reaction that can completely recover. Some of them may develop incomplete recovery and CKD. But without that, without immunological reaction, without an AN or a CAN, whether NSAIDs can induce chronic kidney disease is a questionable thing. So analgesic nephropathy is not a diagnosis we often make. Okay. Having said that, NSAIDs are bad. If you have CKD of any level, your GFR is going to worsen, your proteinuria is going to worsen, your hypertension is going to worsen with NSAIDs, right? So analgesic nephropathy, as of now, the commonly used analgesics, to the best of my knowledge, are not known to as the sole cause of kidney disease producing analgesic nephropathy. No, my answer is no. It is okay to use Meftar or Brufen or Diclofenac when it is indicated. Unnecessary we should not use. When arthritis is there, something is there, it's okay to use. I don't believe it can produce by itself CKD. But they are not very safe drugs, so we have to be mindful in using that. Any role of chronic PPI use increase? So there is some data, but mostly observational data showing that electrolyte abnormalities and higher CKD with the long-term use of proton pump inhibitors, they can of course produce acute interstitial nephritis. So as a general rule, it is not a good idea to use proton pump inhibitors in the long term. We can use it for say 1 or 2 weeks. Long term, even if it doesn't produce chronic kidney disease, it can produce a lot of other issues in your GI tract itself. It can produce hypomagnesemia, which has cardiovascular implications. So chronic intake of PPI is a bad idea. We don't, in our department, we don't prescribe. We prescribe famotidine is our go-to drug for people who need some sort of acid suppressant. Can soda bicarbonate reduce creatinine? No. The answer is no. It cannot reduce creatinine. There was initially, if you look at the earlier CKD recommendations, there was some data showing that it may slow progression of kidney disease. So that is why it was recommended. But subsequently, the data is not very convincing. So as of now, based on evidence, it is believed that correcting acidosis per se is unlikely to retard progression. So we need not use it for that purpose. It will not reduce creatinine by itself, of course. It will not probably retard progression also. But acidosis has multiple other cardiovascular implications, protein catabolism. To prevent that, there are beneficial. So it is recommended when there is significant acidosis, but use it carefully is what it means. Not for everyone blindly. Which drug to give for pain relief in CKD? Paracetamol is my answer. Tramadol is another option. NSAIDs are not a good option at all unless there is some compelling reason to use that. Better not to use. What is generally used is paracetamol, tramadol. In combination, also we can use Ultracet and other things. Management of DKA in CKD is not much different, but diagnosing DKA may be a problem because DKA mostly if you diagnose by testing urine acetone, if the kidney function is low, then acetone may not be there in urine. Patient may have ketosis, but there may not be any ketones in urine, right? So diagnosis may be a problem. And generally DKA you manage by pumping in fluids and insulin. You have to be careful here because the patient may be overloaded. If the kidney function is low, GFR is very low, you can have fluid overload, so you have to be careful. So keeping in mind, one, diagnosis may be a problem. Second, management, you have to be careful with the fluid administration, but with much more closer monitoring, the treatment will largely remain the same. You have to hydrate the patient well. Primary cause for decay, if some infection or something is there, the antibiotic therapy you have to use, and you have to use insulin. The basic principles are the same, but then a diagnosis may be problematic. You have to be more careful about not inducing fluid overload by administering too much normal saline in these patients. Insulin versus oral drugs, as I said, the first line drugs remains the same. Metformin, SGLT inhibitors, GLP-1 agonist, and the DPP-4 inhibitors, sitagliptin, linagliptin. And if you are not getting glycemic control with them, then we can use insulin. Per se, CKD as such is not an indication to start upfront on insulin. Okay, even transplant patients, even some of the advanced CKD patients, we manage with SGLT inhibitors will not have any glucose lowering effect in advanced CKD, but we can manage with sitagliptin and other drugs if they are able to manage. Okay, if you cannot use, for example, glibenclamide because the risk of hypoglycemia is very high, but CKD per se is not an indication to directly go on to insulin. How about serosipeptidase or etoricoxib pain in CKD? Serosipeptidase, no harm. We can use. Etoricoxib is problematic. Etoricoxib has similar effect of nephrotoxicity and interstitial nephritis and cardiovascular events also with etoricoxib. So not a good idea to use etoricoxib is what I would say. If we can use, say, paracetamol and other with serosipeptidase and other muscle relaxants, then of course you can use. But NSAIDs, including COX-2 inhibitors, are are supposed to be harmful, so better to avoid. Excellent session. Thank you, Dr. Jamil. Happy that you enjoyed the session. Will TROP be falsely positive in CKD patients? Yes. Troponins are known to be elevated in patients with impaired GFR. So troponin, even without acute coronary syndrome, this is well known, well documented, both troponin and TROP-I, but interference is less with TROP-A. So in patients with CKD or dialysis, if we are suspecting coronary artery disease, acute coronary syndrome, the preferred troponin is TROP-I. And not only that, it is better to look at serial values, not one value. Even TROP-I can be elevated. So it is always better to look at serial value and see whether there is a elevation of troponin levels. That is more specific for diagnosis of acute coronary syndrome. I'm seeing sort of thank you messages. So happy to get your feedback. Grateful for the invitation and opportunity to interact with all of you at KGMOA. Thank you, Abhilash. I hope there are
Sir,
no more questions.
one last question, sir.
Sure, sir.
I just happened to see a report of a 20-year-old boy in UK. After transplant, he was given bone marrow stem cell therapy, and he's off all the immunosuppressants now for the past 6 months. He's doing well without the immunosuppressants. One Dr. Ravi from Trichy, he has posted it. So, what is your
Yeah, so
comment on this?
that event happened, I think, some time back. So this was in the media. This was reported in journals also. But that's a very unique situation where the patient got a kidney transplant, and then see basically by doing bone marrow transplant, you are reconstituting the immune system also, right? So if it is HLA matched, and so that is theoretically possible. Practically, that situation is difficult because doing a bone marrow transplant is not a simple thing. You have to ablate the marrow, and that itself has significant mortality risk in people with normal kidney function. So that is not something which we can offer as standard of care. So my understanding is that this patient had an indication for patient had a hematological condition which required transplant. So they went ahead with the transplant, and following that, there was immune reconstitution, and the patient didn't require immunosuppression. So that is a proof of concept, but that is very unlikely to become a standard treatment. Is what I'm trying to say, because bone marrow transplant itself is a significant morbid procedure, especially so in kidney patient with kidney disease, people who are immunosuppressed. So yeah, I am aware of that report, but that is a very unique and I would say proof of concept sort of thing. We can learn from that, but unlikely to be a standard treatment option.
Okay, sir. Thank you.
Thank you, sir.
Thank you, Sreejith, for the excellent, brilliant session. I hope we are able to enlighten our doctors. I thank you personally and also in the name of KGMI for the taking the time and effort from your busy schedule. Thank you once more. We will end the session.
Thank you, sir.
Thank you for everyone again for the nice feedback and thank you messages I am seeing, and thank you Abhilash for bringing me on this forum. Good night.
Thank you.